All right. We're going to be starting here just momentarily. Gentlemen, we'll be starting here shortly.
How shortly? Like right now?
Yes.
Oh.
Hello, everyone. I'm Jonathan Gwizdala. I'm going to be talking about diffuse cystic lung diseases in our pulmonary talk today. So just as a little bit of an outline for the presentation, we'll go into very kind of quickly the definition of cysts and then other cyst-like structures in terms of going into more detail into the cystic lung diseases of Lymphangioleiomyomatosis. From here on out, I'm going to be calling LAM, Langerhans cell histiocytosis, Birt-Hogg-Dubé, lymphocytic interstitial pneumonia, and light chain deposition disease. So just starting with what is a cyst in terms of definition. So in terms of with Fleishner Society definition, it's a kind of a round, low attenuation or density area on a CT scan in the lungs with a well-defined interface with the parenchyma, usually thin-walled with less than 2 millimeters, some definitions of less than 4 millimeters, again, usually roundish in shape. And with the thin wall, usually with normal lung parenchyma on all sides of it. In terms of, with that, most of the cyst walls are lined by epithelium, again, with some differences, but kind of differing from a few of the other similarities with the bulla and blebs. In terms of cavity, which is similar to a cyst, it's more defined as a gas-filled space with, again, low attenuation, but within a consolidation mass or nodule, so with thicker kind of walls, usually due to that inflammation or other processes around it. And then there's a thought process of cavities progressing into cysts as kind of like the end stage of a cavity. Next is a bulla, which is emphysematous airspace of 1 centimeter or more in diameter, with, again, a pretty thin wall of less than 1 millimeter. This is usually accompanied by emphysematous changes and in the subpleural area. In comparison to a true cyst or a bleb, the bulla walls are actually lined by connective tissue septa. And then in terms of with the bleb, this is a cystic airspace bounded by thin wall, usually less than 1 centimeter, which is adjacent to the visceral pleura. And in comparison to a cyst or a bulla, the bleb actually lined by the elastic lamina of the pleura itself. So in terms of where it's located and what's surrounded by. And last is a pneumatocele, which is usually round, thin-walled. It's usually air-filled, but can also be filled with fluid. That's usually caused by prior infection, trauma, especially ventilator-induced lung injury or aspiration, and maybe transient. So just in terms of with diffuse cystic lung diseases, there's a few different categories with different disease processes going into each of them. The most common being neoplastic or neoplastic-like conditions with what we'll be talking about today with LAM, pulmonary Langerhans cell histiocytosis, and then other primary metastatic neoplasms. Genetics, we'll talk about Birt-Hogg-Dubé, lymphoproliferative processes like LIP, amyloidosis or the like, and then infectious, and then ILD and smoking related, and then kind of others. So unfortunately, just due to time constraints, we won't be able to cover other processes, especially neoplastic conditions, including sarcomas, adenocarcinomas, metastatic diseases, other genetic conditions, including neurofibromatosis and Ehlers-Danlos syndrome, and then infections, including PJP, staph pneumonias, and endemic fungi, which all can cause cystic lung changes. And then others, including fire eaters, lung and firefighters, and hyper-IgE syndrome or Job syndrome. Then we won't be able to get into the mimics or similar conditions such as emphysema, alpha-1 antitrypsinase deficiency, bronchiectasis, and then honeycombing, also seen in ILD and IPF. So just starting off with LAM. So in terms of LAM, this usually occurs most commonly in those that also have tuberous sclerosis complex. However, this is, as you see, TSC lamb, but there is also a sporadic form without TSC that is seen. In terms of with TSC, about 30% of females who have TSC end up developing lamb, and it could be up to about 15% of males. However, that's kind of a high point. In terms of sporadic, it's about 3 to 8 per 100,000 women, and extremely rare in men. It's actually, I think I found one case report of that occurring in men. And in terms of just average age of symptoms, occurring is around 33 years old. Now, of note, in terms of with TSC, it's usually about 1 in 20,000 births seen in the US. In terms of TSC, it's an autosomal dominant genetic disorder with mutations seen in the TSC gene itself, TSC1 and TSC2, which produce the proteins hamartin and tuberin. These actually kind of have a similarity of causing benign tumors that can occur throughout the body, including CNS, heart, lungs, and dermatologic areas. In terms of with dermatologic areas, you can see other things such as ash leaf spots, Sjogren's patches, angiofibromas, and a lot of other conditions with hamartomas. In terms of kind of the pathology with this, it's believed that these mutations that occur in lamb smooth muscle cells with these mutations have an increased activity of rapamycin or mTOR and have increase in kind of regulated cell growth, survivability, and movement, motility, and kind of moves in a way in terms of a neoplastic-like process. Usually what is seen is these smooth muscle cells proliferate and actually move throughout the lymphatics through the microvascular into the pulmonary interstitium, and it kind of spreads very widely, as we'll see in the CT scans. It then further has destructions in the interstitium with remodeling, causing these infiltrates to become cysts. So just to start with, in terms of some of the dermatologic findings to get away from all the words, on the left here, we have a ash leaf patch. As you can see, hypopigmentation. Here in the middle is periunguinal fibromas, which can be seen on toes of people with TSC. And then on the right is angiofibromas. And this is actually pre and post CO2 laser treatment. You can also see Sjogren's patches, which are the slightly elevated plaques, usually in the lower back, and molluscum pendulum, which I unfortunately forgot to put on this slide. So in terms of LAM, symptoms include dyspnea on exertion, shortness of breath, just constitutional symptoms, but many times they're diagnosed after spontaneous pneumothorax with CT scan. A lot of times chylus effusions as well as chylus ascites can also be seen. PFTs, if obtained, usually show kind of an obstructive-like process or can show an obstructive-like process. And in terms of a lot of times, these are younger females without smoking history, which also gives a kind of a clue for this disease process. In terms of getting a high-res CT scan for evaluation for LAM, again, young to middle-aged women, non-smokers with spontaneous pneumothoraces should kind of be a big red flag. Those with a family history as well. If you find an incidental angiomyolipoma, even with or without symptoms, you should also consider a CT scan. And those with unexplained chylus effusions, especially in women. Those who do have a diagnosis of TSC should have a CT scan every 5 to 10 years at the age of 18 and onward. In terms of radiologic appearances, it's usually more predominant in the mid and lower lung zones, although it can, again, go up to the upper lung zones. It's usually pretty diffuse, and you see a lot of round cystic cysts, which are pretty similar in both size and shape to each other with the uniform. In terms of the size, they can vary anywhere from 3 to 30 millimeters, although usually on this kind of smaller aspect of the cyst size. And they can also increase in amount and size as the disease progresses. So just some images here. So as you can see, it's a pretty diffuse type pattern, both upper and lower, although again, mid and lower lung zones are kind of the textbook presentation. And then it's kind of throughout with the cut across. As you can see, again, all the cysts are pretty similar in size and shape. Again, with some smaller ones, but all kind of looking pretty similar to each other. Here's another one for from our own cohort of patients. Again, smaller cysts, pretty uniform in size and shape with each other. And in this one, as you can see on the right, there's actually sparing in the upper lung zones compared to kind of increase in the mid and lower lung zones. This other patient from our cohort, as you can see, pretty diffuse, small cysts that are pretty diffusely spread, similar size, similar shape. Although with this one, with a little bit more amount of cyst in the upper lung zones. So in terms of diagnosis, so if you have someone with a high-res CT with the characteristic findings and a young female, that should point towards this diagnosis. Other things that can help too is if they have angiomyolipoma or the chylothoraces. Serum VEGF levels can be got and should be obtained. And if it's greater than 800, also points towards this diagnosis, and it can also be used in terms of for treatment. And then if still unsure of diagnosis, TBBX is actually has a decent yield of about 60%. Cytology of fluids from the BAL or biopsy can also give a clue. And then you can do a VATS biopsy, although usually you want to try the less invasive diagnostics first. In terms of treatment, angiomyolipomas should be followed. When they start getting greater than 4 centimeters, they should be considered for embolization or consideration of sirolimus because a lot of times they can start bleeding and actually has a high mortality rate for those patients. So those should be actively followed. In terms of these patients, because of the high decrease in FEV1 from 50 to 250 cc's a year, should have yearly PFTs. Symptom management, the first spontaneous pneumothorax they have occur, you should have pleurodesis, as a recurrence is pretty common in the 30% range. Air travel is usually okay for these patients. And if they have obstruction with reversibility on PFTs, then bronchodilators can be used, and then supplemental oxygen for those who need it. In terms of sirolimus, it's a new option that seems to be utilized, which I'll go into in the next slide. And then last, for those with end-stage lung disease, transplantation being an option as well. So in terms of sirolimus, about 10 years ago, the MILES trial came out, which compared about 40-some patients who had sirolimus for 1 year compared to 40-some patients who were on placebo. They had baseline PFTs as well as 6-minute walks and quality of life assessment. And they continued sirolimus with troughs of anywhere from 5 to 15 compared to the placebo group. What they found, and you can see this on the right side of the screen, is those in the sirolimus group actually had pretty good stabilization of their FEV1s as well as FVC. And actually about 46% of the sirolimus group had stayed at or were above their FEV1 PFTs from their baseline. And there was about 150 cc difference per year between the two groups seen. Of note, there's also a difference of about 225 cc's in the FVC, with improvement in the FVC seen with the sirolimus group and better overall quality of life. Of note, once the sirolimus was discontinued at that year, there was a continued decrease as seen in the placebo group. There was more side effects with sirolimus, with mucositis, GI complaints, lower extremity swelling and rash, but overall pretty minimal. Ando et al. From coming out of Japan had taken a look at 15 patients with actually troughs that were less than 5, which had similar results, but with less side effects seen. And then more recently, Hu et al. From China took a look at a group of about 150 some patients going back over a 4-year retrospective evaluation for a longer term use of sirolimus again, showing continued stabilization in their PFTs, quality of life, with, again, kind of similar amount of mild side effects. So overall looking like a better option for those with LAM. In terms of starting sirolimus, right now it seems like those that have an FEV1 of less than 70, a loss of greater than 90 cc's a year, those who have chylothorax or chylosocieties or continuous chylothorax, those with angiomyolipomas, again, starting to get into the higher sizes, greater than 3.5 to 4 centimeters, those who have repeat pneumothoraces, and then stabilization of patients waiting transplantation. In terms of the current trough that we are looking for with these patients, it's usually between 5 to 10, kind of on that lower side to try and decrease symptoms while still having the benefits from the sirolimus. Next on our list is looking at pulmonary Langerhans cell histiocytosis. So in terms of this tends to be a diffuse cystic lung disease seen in young patients, active or prior smokers, or have a significant secondhand smoke. It's about 80% of case reports had noted these patients having a high amount of smoking or substantial secondhand smoke. On average, it's about 2.7 per 100,000 men, or 0.7 per 100,000 for women. So on average, more common in men by a factor of about 10. In terms of this, what we see is there's likely some sort of activation of Langerhans cells in the peribronchial area due to smoking. That also causes genetic modification, activation, disruption of these Langerhans cells. These then are activated and usually persist and cause further recruitment of immune cells, inflammation, and then remodeling of the areas causing the cysts. Of note, usually there's the mutations of BRAF, ARAF, and MAP2K being seen, with about 50% of patients having either BRAF or MAP2K being seen. Something just in terms of for boards, pathology and histology wise, Langerhans cells stain in these situations with S10 or S100 and CD1A. And also on biopsy, you can sometimes see smoking-induced RB as well as DIP. So in terms of symptoms, a lot of times it's kind of mild shortness of breath, mild cough, but pneumothorax, again, which seems to be a common complaint seen in these patients, or common sign seen in these diffuse cystic lung disease patients, can also be seen. In terms of PFTs, they can show normal, restrictive, or obstructive process, with restrictive being seen earlier on within this disease, and more obstructive the more chronic this becomes. In terms of when to consider, young to middle-aged cigarette users who have exposure, who don't really fit that emphysema-like picture yet, as well as the cystic findings on radiology, if there's usually found incidentally, as well as those who have spontaneous or recurrent pneumothoraces, skin findings, which I'll go into in 1 second, as well as those with diabetes insipidus, which is kind of very common in these patients. Also, family history of pneumothoraces can also be seen and help kind of point towards this disease. In terms of findings on radiology, a lot of times you see upper and middle lobe predominant, nodular, cystic, cavitary-like changes. A lot of times you'll see nodules as well as cavities. Usually they're very bizarrely shaped, especially as they grow. And they're usually anywhere from 2 millimeters to 2 centimeters, but can sometimes be larger. One of the things that's good to know for this when you're looking at radiologic imaging is there's pretty amount of sparing of the costophrenic sulci. And again, there's this belief that the nodules form into cavities, then form into cysts in terms of what we see. So in terms of some imaging, as you can see in the top left, there's some cysts as well as cavities, which are seen along with some ground glass areas of consolidation. Not as diffuse, not as numerous as seen in lamb, but it's still pretty present. In the image below, again, thin-walled cysts with some cavitary lesions as well, and some nodules seen kind of throughout the lungs. And then on the right, cyst cavities and nodules kind of with sparing of the sulci, as you can see. Another good examples, kind of with roundish shape, but very irregular in terms of the overall borders. A lot more upper and middle lobe predominant, kind of just odd in terms of how they're shaped. They're not not very uniform in terms of how they look compared to lamb in comparison. And then again, with the sulci being relatively spared. And another patient of ours in terms of who has cysts kind of in the upper and mid lung zones with sulci sparing, and with areas of both nodular as well as cavitary-like areas. So in terms of diagnosis, again, high-res CT can give a presumptive diagnosis in the appropriate setting of a young smoker. Usually, though, definitive diagnosis is needed with biopsy, again, also to rule out other processes. What can be seen in terms of this is transbronchial biopsies have about 30 to 50% diagnostic workup, but can exclude other diagnosis, with VATS or extrapulmonary biopsy being a definitive diagnosis. In terms of PET scan would be positive, but can assess for other extrapulmonary disease processes once there's a definitive diagnosis. Other things that can be useful is urine studies in terms of those concerned for diabetes insipidus, as well as echocardiogram to assess for pulmonary hypertension. In terms of treatment, the things to know about this is smoking cessation is kind of a must. With smoking cessation, there's 25% regression, as well as stabilization. A lot of times you treat symptomatically in terms of if there's any pneumothoraces with pleurodesis, treatment for their GI and treatment for their pulmonary hypertension. In terms of pharmacotherapy, corticosteroids and vinblastine as a combination is the go-to for juvenile Langerhans cell histiocytosis, and in adults tends to be less tolerated, and also seen as in adults, it tends to not help pulmonary Langerhans cell histiocytosis as much. What has been seen is cladribine more recently having about an additional 36% improvement, as well as 64% stabilization for pulmonary Langerhans cell histiocytosis in terms of pulmonary function parameters. And then if you still have continuation, then there have been case reports and I think even phase 2 trials of BRAF and MAPK inhibitors for those that have genetic predisposition for that. Going on, we have Birt-Hogg-Dubé syndrome next. This is an extremely rare disease. There's probably underreported as well. There's about 200 families known worldwide. And the NIH, they have 89 patients with about 51 families, with 84% of the NIH patients with cystic lung disease being found. It is of note that there's about 30% of lung cysts develop pneumothorax, but you don't necessarily need the cystic changes to have a pneumothorax with these patients. This is an autosomal dominant disorder with genetic alterations of FLCN or folliculin, which is a tumor suppressor gene, and believed to cause also dysfunction in the mTOR pathway. It is kind of unknown exactly what causes the cystic changes in this process, but they believe that it has to do with the adhesion protein having defects or deficiencies, which lead to alveolar septal junction insecurities and weakness, causing tearing by just normal mechanical forces during respiration. Of note, too, is that cysts, if they develop, usually occur in the 4th to 5th decade of life. You also have a high percentage of patients who develop kidney tumors and also have kind of dermatologic findings such as fibrofolliculomas and dyskomas, as well as skin tags. So in terms of a few things, so the pathology on the lower left, you can see a cyst with a intraseptal or septa being pointed at by the arrow. The picture with the C is actually fibrofolliculoma, as well as seen as fibrofolliculoma with the arrows pointing behind the ears, which are discolored to a whitish color compared to these trichord dyskomas, which is in the bottom right, which tend to be the same color as the skin. So in terms of signs and symptoms, usually spontaneous pneumothorax kind of are seen again in these patients. The skin changes as we saw, and then kind of incidental renal tumors being seen is not uncommon. And renal tumors are seen about 25% of BHD patients, usually with the average age of around 50 years old. And they can be anything from adenomas, oncocytomas, they can be bilateral, and they can also be multifocal as well, as we'll see. So in terms of also diagnostic consideration is people with family history, that should be a kind of a red flag, the skin findings, pneumothoraces, and then the radiologic findings, usually predominantly having in the basilar locations being subpleural and being kind of this elliptical form in terms of shape. You can also see these cysts abut the pleura as well, proximal vessels, to kind of make it look like the vessels are either going through or into the cysts themselves. So here we see that there's kind of cysts that are predominantly in the lower, mid and lower lobes, although they are starting even in the upper lobes here. They're not necessarily small, but kind of odd shaped in terms of more elliptical. And they're usually abutting some of the structures, whether the vasculature or the pleural spaces, which is easier to see in this one, kind of more medially, but a lot of sparing in the upper lobes too. Also seen on the pictures on the right are two cysts that are seen within the kidney, including one larger one, which is also a good thing to know. And I think this was actually a case that was presented at chest x-ray conference not too long ago. Additional imaging just shows cystic changes, again, in the middle and lower lobes, kind of this elliptic form shape as well. So diagnosis, if you have some skin involvement, as we saw the CT findings, usually in these patients, you want to get genetic testing, especially those who have family history. And in terms of these family members, usually should also have genetic testing and counseling done. For management of these patients, CT chest, abdomen, pelvis, if they are positive for the mutation, even if asymptomatic. Pleurodesis is usually needed after the first pneumothorax, again, because recurrence is pretty high. These patients should have caution with diving, shouldn't go scuba diving. Usually flying is okay, but again, it depends on their disease progression. In terms of renal tumor screening, that should occur starting at the age of 20 with MRI every 3 years, and that's MRIs to decrease the amount of radiation exposure. And then with tumors that are greater than 3 centimeters, nephron sparing resection is recommended. Okay, next will be lymphocytic interstitial pneumonia. However, prior to that, I have a quick question for you all to think about throughout the day. Is the word lung membrane singular or is it plural? There you go. You're welcome. So, lymphocytic interstitial pneumonia. It's associated, it's a cystic lung disease associated with many autoimmune processes and infections. It's very highly related with Sjogren's syndrome specifically, but can also be seen in rheumatoid arthritis, HIV with AIDS, Castleman's disease, CVID, and amyloidosis. It's kind of unknown specifically in terms of specific predominance, but it does occur in both sexes. and the mean average of about 47 years old in terms of diagnosis. What is seen is that there seems to be hyperplasia and expansion in the interstitium of lymphatic cells that then have fibrosis. And this fibrosis can cause congestion of the airways, the vasculature, and even cause bronchiolar ectasia with a one-way valve creating these cysts. In terms of the histology and pathology, usually dense interstitial lymphocytic infiltrates are seen with plasma cells, B cells, T cells, with nodular aggregates, with the germinal center even seen pretty commonly in those with connective tissue disease. And usually those germinal centers are seen peribronchially. So in terms of just a histologic slide, we see a bronchiole with the BR with a bunch of what looks like B cells, germinal center kind of surrounding that area. And then kind of expanded out, you see a cyst form with the star. And that kind of gives you kind of an idea of what's occurring. So with that, what we see usually is a diffuse, with the signs and symptoms, kind of a diffuse amount of coughing and dyspnea. We do see fevers and night sweats as well as weight loss. PFTs, a lot of times with restriction, always with kind of a diffusion impairment. And then those that have more obstructive process can have air trapping, although less commonly seen. When to consider it in terms of patients is those that have Sjogren's syndrome or an autoimmune condition, kind of with a radiologic findings being seen. In terms of the radiologic findings, ground glass opacities, central lobular nodules, and cysts are usually seen again with the belief of nodules becoming cysts. There seems to be a kind of random distribution of cysts and can even be unilateral. And then a lot of times there's internal structures seen within the cysts, which I'll show kind of with vessels coursing through the cysts themselves. Other things of note is with the size of these structures being anywhere from 1 millimeter up to 30 millimeters, but there's not kind of a uniform size that is seen. So again, the distribution is random, but it's not as significant as some of the other disease processes. As you see in the left image in the right lower lobe, there's actually a vascular structure going through the cyst itself, which is seen in both LIP as well as the next disease process. But if you see that, that has a kind of should have a high suspicion in terms of LIP, especially in those people that have autoimmune processes. In this image set, you see both a kind of ground glass nodular appearance in the left upper image and the right lobe, and then a cavitary lesion in the left image, in the right image, in the left lobe. And then in the bottom image, you see kind of a distribution of cysts as well as a cavitary and ground glass that is seen. And here's another example in terms of if you look at the image on the left and the right lower lobe, there's the cyst in the periphery that has a vessel going through it. And then in the right image, in the left lower lobe, there's another cyst that has the vessels going through it. Again, something that seems to be seen pretty commonly with this disease process. In terms of diagnosis, so in the setting of an appropriate underlying condition, or if you find this, then looking for an underlying condition, this can avoid the need for biopsy, with starting treatment. However, tissue confirmation is usually needed also to rule out lymphoma as well as MALT. In these cases, transbronchial biopsies tend to be low yield, so usually surgical lung biopsy VATS is the gold standard. If you do a BAL in these patients, though, you will have a lymphocyte predominant cell count. In terms of management, it's a highly variable course. Even those who are getting treated, only about 1/3 of them can progress even while being treated. Immunosuppressive meds for those with Sjogren's, such as steroids and steroid-sparing medications, are useful. antiretroviral with HIV and AIDS. And then even those people who are being treated, if further ground glass opacities or consolidations happen, biopsying of those area. And there's about a 5 to 10 year kind of median survival seen in these patients. And to finish off the talk today, we'll be going over light chain deposition disease. So in terms of this is a disease process which is very similar to amyloidosis, but with light chain, it's usually kappa light chains that are deposited in the kidneys, in the heart, and the lungs, and the liver. So unlike amyloidosis, they're unable to make amyloid fibrils due to biochemical nature, and then unable to make the beta pleated sheet figuration, therefore are not seen with Congo red staining. And also there's no apple green birefringence with polarized light. And in terms of with this disease process, about 70% of people have kappa light chains as the primary light chain. And this is when it was originally seen in patients in the 1980s. They had actually been priorly diagnosed with either PLCH or LAM. So in terms of there's a kind of a wide variety of what the appearances can look like. And in terms of how this comes about, is the belief is, or what is seen as these kappa light chain deposits usually occur in the alveolar walls, in the airways and vessels throughout the lungs. These cause further emphysematous-like changes, and on electron microscopy, what is seen as granular deposits along the basement membrane, again, seen also in kidney biopsy if there's kidney involvement. And there's a belief that these deposits cause inflammation, increase metalloproteinase activity, and therefore decrease the form of the alveolar walls and cause further cyst formation. So in terms of more histo, which is everyone's favorite, what we have here is eosinophilic deposits around an area of the multinucleated giant cell, which is pointed right in the center. The same image, if it were to be, it would be negative if it was under polarized light for birefringence, as well as Congo red. However, as seen on the image on the right, there is positive anti-kappa immunofluorescence seen with all those brown kind of areas. So for most patients, usually cough and dyspnea is pretty common. You do see obstruction or restriction on PFTs, again, depending on where the deposits are seen. A lot of these patients end up with kidney involvement, with the most common presentation of organ involvement in LCDD. There's a better prognosis for those when they're originally diagnosed who have a better GFR, younger age, and a slower progression of their chronic kidney disease. Also can be seen as restrictive cardiomyopathy, liver and other GI dysfunction, and then neurologic dysfunction as seen in like amyloidosis and neurologic conditions. Of note, in terms of prognosis, when kidney involvement is seen, there is usually about a 32% mortality at 18 months. So it's can be a pretty devastating disease. In terms of pulmonary wise, radiologic features with this cystic disease is usually diffuse random shapes. The sizes can be bigger, up to 5 centimeters. There's also nodular and consolidative changes seen, as well as calcified nodules. Can be unilateral as well as bilateral. And you can even see an area of just one specific cavity with further cysts and nodules being seen. So just looking here, again, it's usually going to be by vessels, with vessels sometimes also being noted to being going through the cavities, as seen with the image on the left. In the image on the bottom left, you see a kind of calcified nodule as well. And then on the right, there's a kind of blow up on the image showing a cavity with the vessel kind of going right next to it as well. So it's usually has the kind of abuts both vessels and other, I guess, vessels that are seen with these cysts. So again, associated conditions with this, multiple myeloma, other plasma cell dyscrasias. A lot of times there's family history of lymphomas with these patients. In terms of with diagnosis, electrophoresis can help. However, in terms of either serum or urine, if there's only pulmonary involvement, it may be negative, and serum-free light chain analysis is needed. Lung biopsy with histopathology evaluation is usually needed in these patients, and if there's kidney involvement, it can be done by the kidney. And a lot of the times, if there's biopsy of the lung, it's also to rule out a malignancy or other processes. In terms of treatment, kind of unknown pulmonary progression for those that have it. Treatment of underlying hematologic disorders is usually useful with bortezomib, rituximab, thalidomide, doxorubicin. For those who have renal involvement, dialysis eventually is usually needed, as well as you can have treatment of other organ dysfunction such as restrictive cardiomyopathy. In patients that do have involvement without multiple myeloma, with multiple myeloma and with extrarenal involvement, allostem cell transplant can be utilized and has been utilized. And those without multiple myeloma, hematopoietic stem cell transplantation can occur. But a lot of times these patients go towards needing either kidney transplantation or in some cases lung transplantation. So unfortunately, there's not a lot of great treatment. Thankfully, it's not a very commonly seen disease process. This is probably the highest yield for all the fellows in terms of comparison between these 5 different conditions. In terms of the size and shape, unfortunately, a lot of them are cysts and they're round and they can be different sizes. So it's not always the easiest for comparison, but location I feel like is going to be a big one to help. In terms of with PLCH, seen in the upper lung zones with sparing of the costophrenic angles. Then with LIP being near vessels and having internal structures. And then with Birt-Hogg-Dubé being in the inferior aspect in the subpleural spaces. Also, a good thing to know is if there is nodular involvement, that can help differentiate between the different processes. And then additional findings can also help. So in terms of doing a full examination of the patient, skin examinations, evaluation of renal involvement kind of can be helpful. Last thing in terms of with the high-res CT, so in terms of like LAM, chylothoraces, I've seen a lot, so those pleural fusions. And then of last is in terms of for kind of boards and board knowledge, the diagnostic and genetic aspects for each of these. So with LAM having the TSC1, TSC2, as well as VEGF levels. With pulmonary Langerhans cell histiocytosis, it's the CD1A and S100, along with the BRAF and MAP2K. With Birt-Hogg-Dubé, knowing the folliculin gene with FLCN, and then with LCDD, kind of being able to differentiate it from amyloidosis with no Congo red or birefringence being seen. So with that, thank you everyone. And if there's any questions, please let me know. Okay, I don't see any questions up here, but if you do, you can ask me later on. Thank you.